Hello everyone and welcome to a new session of clinical pharmacology and clinical research. In this session today we are going to speak about hyperlipidemia, clinical pharmacology questions using Bloom's taxonomy, addressing three or like six level of Bloom's taxonomy, start from remembering to understanding, applying, analyzing, evaluating, and finally creating. Okay, let's get started. Okay, regarding remembering level of Bloom taxonomy, which of the following is statin is used to lower LDL cholesterol? A. Gemfibrozil, B. Nystatin, or C. Atorvastatin, D. Ezetimibe, E. Niacin. So the correct answer will be atorvastatin. So you can see here we have the suffix nystatin and atorvastatin. We have the same suffix. Okay. And nystatin antifungal medication. And statin belong to the HMG coenzyme A inhibitor. Okay, next, understanding, summarizing, explaining the information. How do statins primarily lower cholesterol level? Here we asking about mechanism of action. How statin lower cholesterol level? A. Statins inhibit cholesterol absorption in the intestine. B. Statin inhibit HMG CoA reductase in the liver. Or C. Increase lipoprotein lipase. D. Enhance bile acid excretion. So the correct answer will be inhibit HMG coenzyme A reductase in the liver. HMG stands for HMG coenzyme CoA reductase stand for hydroxymethyl glutaryl coenzyme or coenzyme A reductase. This is the correct answer. And this enzyme responsible for synthesis of cholesterol, and statin inhibit this enzyme. Okay, next, applying or application using knowledge in clinical scenarios. 58-year-old patient with type 2 diabetes and elevated LDL is prescribed simvastatin. What additional benefit does the drug provide beyond lowering lipid? Improve insulin sensitivity, reduce risk of cardiovascular event, prevent microalbuminuria, or increases HDL dramatically. So what additional value here? So the patient suffer from hyperlipidemia, elevated LDL, type 2 diabetes, and you prescribe statin. So what is the benefit beyond lowering LDL? Okay, so the result will be reduced risk of cardiovascular event according to the medical literature and published articles. Okay, analyzing, breaking down complex clinical cases or discussing lab data, lab results. Here we have a patient on statin therapy developed muscle pain and elevated creatine kinase. Which drug interaction is most likely responsible? So here the situation will be the patient on a statin, and this patient suffer from muscle pain, elevated creatine kinase. So which interaction is most likely responsible here? So here the situation, okay, simvastatin ezetimibe, atorvastatin niacin, rosuvastatin furosemide, or bravastatin aspirin. Okay, niacin, atorvastatin will be the correct answer here. With the muscle pain, niacin and atorvastatin will be maybe more obvious side effect related to this medication. Okay, evaluation, judgment, prioritizing treatment. Which patient is the best candidate for initiating high intensity statin? Here we need to go to the table and remembering the category of statin according to the high intensity, moderate intensity, and low intensity, and remembering the maybe the candidate for that. A 30-year-old patient with the LDL cholesterol 120 milligram and no comorbidity. Okay. B 52-year-old patient with a 10-year atherosclerosis risk factor 5%. Or C 45-year-old patient with a history of myocardial infarction and LDL cholesterol 160. Or 60-year-old with controlled hypertension and LDL cholesterol 90. Okay, so which one will be the candidate for the high intensity statin? So the correct answer will be 45 years old with a history of myocardial infarction MI and LDL 160. And if you look what we have here, we have a clinical cardiovascular disease, myocardial infarction, and LDL cholesterol 160, and the normal should be less than 100. So this is the maybe the best candidate for the treatment with a high intensity statin. Okay, the final question according to the Bloom's taxonomy of hyperlipidemia about creating treatment plan. As you can see here, creating treatment plan, modifying regimen of treatment. Create treatment plan for 65-year-old patient with a mixed dyslipidemia. The patient suffers from high LDL, low HDL, and elevated triglyceride. A. Statin monotherapy only. B. Start niacin and bile acid sequestration. Or C. Combine statin with the fibrate if triglyceride above 500. Or C. Use omega-3 fatty acid only. Okay, it's not C, omega-3 fatty acid only, because this one will be target triglyceride or most of the time. Monotherapy statin mainly lower LDL, and combines niacin and bile acid sequestration is not the first option for the situation here. Could be option. The correct answer will be combine statin with the fibrate, especially if we have triglyceride above or more than 500 milligram per deciliter. Okay, this will conclude our hyperlipidemia clinical pharmacology review question using Bloom's taxonomy. Our next session, we are going to speak about COPD, which is a chronic obstructive pulmonary disease, a clinical pharmacology question. Thank you so much for your time and have a great day.